Hello and welcome. I'm glad you could be with me tonight because I have a guest you're going to find very interesting, and he'll tell us a lot about the state of healthcare today. I'm with Dr. Scott Davies today, and Scott is going to be one of my leadership guests for my ongoing series because, for many reasons, but because he's a beloved physician here in Minnesota. He's won lots and lots and lots of awards. He has been the chief of medicine at Hennepin Healthcare from 2002 to 2017. He also was the director of the Department of Pulmonology and Critical Care for several years. He's a pulmonologist that is still working, but not full-time as of just a little bit ago, right, Scott?
The last year or two, I've been working only in the clinic, and I stopped doing the ICU, and I stopped doing nights and weekends, which is a good thing.
A good thing for you.
Yeah.
But you're also still teaching.
I'm still involved with resident conferences.
Students from the University of Minnesota. And you're a professor there in the Department of Medicine.
Yes. So,
busy man still. And as I said, one of the most respected doctors in our state. Well, you grew up in a family of 10?
9 children.
9 children. Yep. Do you think in any way that prepared you for the multitasking you have to do as a physician at Hennepin Healthcare?
I haven't probably so. I mean, there's a certain amount of chaos in big organizations, and probably in big families. Good kind of chaos.
Where were you in the 9 children lineup?
Kind of an unusual. My sister was born first, and then we had 8 boys in a row, and I was the first of the boys. So I was second in
8.
First of
so
the 8
there
boys.
Was some
so I have
prestige,
7 younger brothers.
Some leadership skills that maybe came out of that position.
Yeah, my sister was a good leader, though. She was. She was about 3 years older, and she took care. She had a good leadership position in the family as well. She ended up in leadership in nursing at Mayo and worked there for her career.
She did. Okay,
so
another
she was a good role model.
Medical person. When you think of your work at Hennepin Healthcare, and you think of all the awards you've won and all the patients you've worked with so intensely, what are you most proud of, Scott? I mean, it's hard to ask or hard to speak to that, perhaps, but I'm curious.
Well, I think one thing is the department. You know, I'm in a big department with 100 physicians and 40 nurse practitioners and advanced practitioners. And it's mainly that a lot of the thing is hiring the right people over a period of years and developing them and being able to create the kind of environment that really works in service of the patients. So I'm, having built a team first in pulmonary medicine, critical care, and then sort of working very hard to. So that's one part of it. In the team that the department is a wonderful department.
Your pulmonology
and the Department of Medicine as well.
Right, the whole big
and that's department. a lot of the job is recruiting and retaining the right kind of faculty in the right kind of positions. I guess the other thing is the work at the University of Minnesota, because Hennepin is it's a public teaching hospital, so the middle name of the place is teaching, and that teaching is at 2 levels, and one is with the first and second year medical students, there's some teaching in pulmonary physiology, and I did that for many years, and so I met those all the students going through the University Medical School for 20 years. And then the students come to the Hennepin, and of the 3rd and 4th year, which is where students are taking their clinical rotations, the majority of the biggest single teaching site of the university is Hennepin, probably 35% to 40% of all the clinical rotations for the 3rd and 4th year at Hennepin, across all disciplines.
So no wonder people know you all over the state because they're doctors.
For 20 years I taught most doctors at the University of Minnesota.
Yeah.
But that is one thing, is that Hennepin is a partner with the university in really training the next generation of physicians for the state of Minnesota.
I think that's something that the general public doesn't really see or realize to the degree that it's a partnership that way.
It's a lot. I mean, the university has many teaching hospitals. So there's the VA, and there's M Health Hospital now, I guess is the current name,
Right.
and there's Regents
Another
name, and Regents Hospital, and Abbott Northwestern. So all of them are teaching hospitals. But the connection with Hennepin is a particularly strong one, and it's by far the most, the most number of student weeks throughout the year at Hennepin. And at one time, a quarter of all physicians practicing in Minnesota had spent at least some time at Hennepin, either as students or as residents in their training there.
Wow.
So that's a pretty. So I'm proud of helping to train the next generation of physicians throughout.
That's
as part
a
of my career.
huge thing to think I've been a big part of this.
Yeah.
And from what I hear talking to other doctors, your collaborative style, listening to others, respecting their opinion, not being the authority all the time, really has been part of the secret to their love of you. Would you agree?
Yeah,
I guess I'm sounding like a question.
I'm not too authoritarian. That's probably true, but on the other hand, you have to have. I think part of it is basically recruiting and retaining people who share similar values and who have the same focus, and then maintaining a connection with them, wanting them to have a good job, wanting them to like what they're doing and enjoy coming to work, and trying to figure out what the barriers are to that.
What I read about the work of physicians in the last several years is that it's getting more stressful and more burnout, suicide, that's pretty high rates. Do you see this sort of downward trend in satisfaction going on, or is there hope for changing and getting it going the other direction?
Yeah, there's a lot of pieces to that, and one is that physicians were a profession that had professional relationships, doctor-patient relationships in that strong sense, and they had a fair amount of resources and control of what they did. And now physicians have become providers and employees, and so and more regimented. So even though they have to work hard in hours, they have somewhat less control of the day-to-day things that they have to do, and
more pressure to see more patients.
Well, to do it in a certain specific way and to make decisions based on which are, in general, to be on board with the focus of the health, the health organization. So that's the employee part, and then you couple that with the electronic health record, which has been a very mixed.
Yeah, that's
a very mixed thing. It's important, and there's many positive aspects to it, but it sort of magnifies some of the. How do I say this? The perverse incentives that are built into that are dissatisfying.
And it can take away some of the patient-doctor relationship in the time you're together.
Well, in the exam room, it's a difficult thing. Obviously, if the person is looking at the screen and typing away and not looking
which
at
some
you,
doctors
it's
do
a difficult
and probably
thing.
have to do.
On the other hand, if you, my clinic life is different because I work several sessions of clinic a week, but I don't work 9 sessions of clinic a week.
So you've got some time to do your charting.
I can do the charting
later.
So that's a luxury, though. That's not.
Not everybody gets
that luxury, and so then you have to figure out some way to. And the documentation, not all of it is for the patient. Some of it's very redundant. And it's basically the
for
whole
the insurance
for the
people.
Billing and documentation, and then the reward is for how much billing you do, and that depends on how many things you do and what you, and not that connection with the patient. So that's a difficult thing,
and a big thing too, isn't it?
Is
I mean,
a
it's
thing.
a major.
It is
kind of a tricky thing to.
And people are working on scribes, but I don't think that So you're in the room with the third person, and then
Right.
you're just I'm talking to you, but
Right.
I've
They're
got
taking notes.
They're taking notes, and then I check their notes, and I've never done that. We do have it in a lot of places.
And when notes are checked, they're not always quite what you would have charted, probably.
I guess they can't be perfect, but I don't think they're that. I think the scribes are pretty good, but it adds a whole nother layer of costs and redundancy. It can't be.
And there's time involved in reviewing what they wrote too, so you don't have the gain maybe.
And then they can't enter orders.
Right.
And the orders are all
have to be
direct entry things. So
it's some pros and some cons,
so
I guess.
I think the shift between professionals with more autonomy, work hard. Physicians have always worked hard. Part of it is the hours, and part of it is the complexity. But now it's the shift toward being a provider and an employee, and doing that well while having less control and sometimes less resources. Mm-hmm. And the resources are distributed according to the revenue. So internal medicine is, it's not like if you're a doctor who is putting in pacemakers.
There's a lot more money involved.
There's more money, so you are supported. You can be supported at a higher level. Or if you're doing thoracic surgery or brain surgery, but if you're in internal medicine and you're seeing patients in the clinic,
or family doctor,
or any primary care doctor or primary care provider. Mm-hmm.
I see what you're saying.
But so is there? I think there. But I still would say it's the best job there is.
Would you?
I would.
See, one of my other questions is, would you advise one of your grandkids to go into medicine?
If it was something they wanted to do, I would. I can't imagine better.
Okay.
I'm happy that I did it because it all comes down to the individual connection
with the patient.
Sharing the joy of getting better, sharing the sadness of not being able to get better.
But being that person that is trusted and the patient can lean on you. I've always thought that when I have a good doctor, it takes so much of the stress off my shoulders because I sort of share it with the doctor. And that is what you're talking about partly, right?
I think so.
When I think about Hennepin Healthcare, I think that the wonderful report that I remember reading years ago still holds, that if you are an adult and you have a crisis, the place to go is Hennepin Healthcare. That is something that I don't think everybody knows. And can you explain why that is the case?
I spent my whole life working in an intensive care unit, with patients who require life support. They're on ventilators.
They're really, really sick.
And ventilators, and they're getting medicine to support their blood pressure, and I've always been very proud of that we've had great outcomes in the ICU. But the reason we have good outcomes is because we're part of a system of care that serves the community, And so you have to have paramedics. We really expect if we call 911 and there's something acute happens that someone will come in 5 minutes. That's not true.
All over the world.
Sometimes it's 911 might be an hour, might be 2 hours, might be whatever.
We're spoiled then here.
And the people we have, the EMTs are trained. They're very well trained to their jobs, and then we have to have ambulance, system of EMT stabilize. What do? Is they stabilize, resuscitate, stabilize, transport, and then they come to an emergency room that's in direct connection with the ambulance system. They train the EMT system. They support it, and what does the emergency room do? Is they do volume resuscitation, airway management, oxygenation. They do, and then they diagnostic things. So they figure out, does this patient have to go to the OR, or is this patient who has to go to the ICU and get antibiotics, blood pressure support, sepsis treatment? And then they get up to the ICU, and we have all trained, a nursing staff that's wonderful, and that's a place we do have lots of support. So I could work in the same ICU with the same team and have horrible outcomes if the paramedics got there 15 minutes later and the ED did not adequately volume resuscitate and start these things. So it's part of a system.
The building blocks start at the bottom, right?
In other hospitals, obviously, we do 80,000 ambulance runs a year.
Wow, 80,000.
Last year, 80,000 ambulance runs a year.
How would that compare to another private hospital?
Well, I mean, that's the system. We get, the ones who come to Hennepin are probably 40, because we transport patients to any hospital the person wants to. If we come, but we probably have 40,000, over 100 a day that come to Hennepin. We're transporting patients for.
That's a lot of crisis.
That's a lot of
management,
crisis.
isn't it?
It is, and some of it's quickly reversed. Like like an allergic reaction where you get an adrenaline shot and you're
choking, or
there's lots of things that are quickly reversed, but some that require a lot of effort. And so that is why the whole system of care and the participation in it is why Hennepin's a good place. It's the strength of the ICUs connected with the strength of the emergency departments, connected with the connection and the continual training of EMTs and what happens in the field, what happens in the emergency room. And we do deliver very good outcomes for acute, serious things.
That's really good to hear. And you also have, perhaps, I'm remembering this wrong, but I've read that you have more specialists on call right there. I mean, not that you have to bring in, that they're in the building.
That's part of the level.
Any other hospital.
Level
except
one,
regions.
Yeah, level one trauma requires you to have a certain, you have to have access to surgery in-house, anesthesia in-house, these different.
So
and
we
have
not
people
having
on
to
call.
wait to pull doctors in from who knows where.
And all the other supports that, some of them are difficult to maintain, like eye trauma is difficult because people don't want to make a mistake about someone's trauma to someone's eye, and so I think we are the only ones who have eye surgeons who are on call.
And your burn unit is really special, from what I hear.
Yeah. So part of that is the fact that and part of that is a public hospital is only going to work if it serves the community that it's in. And part of that is having a special set of competencies that are needed by the community, and then doing a good job delivering care in those areas.
Do you think it's fair to say that in order to keep viable, though, you need to pull in more private pay people who aren't on Medicaid or Medicare, who are able to pay more per visit?
Medical economics is complex, and it's been shifting.
Yeah.
A lot of people think that Hennepin, that people at Hennepin don't, that it's a free hospital or something like that. And we do treat, part of a public hospital, a public safety net hospital, is we treat anyone.
So you don't have to have insurance.
If you show up, we're going to do our very best, and if we can enroll you in something, we can, we have systems to do this, but we will treat first and then try to figure it out later in terms of those things. So there aren't eligibility requirements. You can come in. But the number of patients we have that are actually uninsured totally what would you guess that would be? I ask people around the country.
The fact that
what does the public think of that?
Probably.
What does the public think would be the percentage who are
And I've not read that number, so it's going to be a totally public kind of guess here. I think my perception is that over 50%.
Well, it's about 3%, okay?
It is, Scott.
Because Minnesota is, we're all aware of the ACA and the Obamacare and the development of broader coverage. And Minnesota has had that for a very long time. Our state has been very proactive in expanded Medicaid compared with, and has made further improvements in reimbursement and since the ACA, so that we have a state that is very.
So if the court, when they get the case that says, should we do away with ACA? When the court gets that in, if they agree with that and it disappears, can we still hang on to the system we've got here?
I don't know. I mean, I think certainly the state of Minnesota is committed to, just like the state of Massachusetts, there's others, the state of Hawaii, there's states that are committed to trying to have some kind of insurance coverage for
everybody,
people to the best of their ability. And we've been and one of the reasons Hennepin has been viable is because of that. It's not because we get subsidies from this or that. We provide care for patients who have insurance. Patients with Medicaid can also join health plans and go to anywhere they want. There's no one who is forced to come to Hennepin. We have to provide good care, and we have to have services that meet the needs that are harder to serve in other settings because of the focus that we do, and we have to be attentive to that. But there's not a Medicaid plan that lets you only go to Hennepin.
Right.
That is not.
Right.
In
And
Medicare,
that might be a
go.
misconception.
It is a misconception.
That I think the public
so.
might have.
Right.
Well, I want to shift. We've only got about 8 minutes left. I want to ask you some kind of general questions.
Okay.
As a pulmonologist, we're taping this, I should tell you folks, on February 10th of 2020. Just today, I got my Time magazine in the mail, the coronavirus. We're starting to get a little more worried, I think, all over our country, even though very few cases. How worried are you, Scott, as a pulmonologist?
Well, I think, one, as a public hospital, we're doing a lot of preparedness work. So there's not myself, but people in our emergency preparedness area working with the state, working with the health department. So there's a lot of thought playing out different scenarios of what could happen. It seems, it seems to be a virus like influenza, a respiratory virus that spreads from people to people, person to person. Unlike the other coronaviruses, SARS and MERS, the Middle Eastern one, those did not tend to spread until patients became febrile and were sick.
And more people have gotten this new virus.
This new virus is behaving more like influenza in terms of how it spreads from person to person, that it seems to spread before you get sick. So it's hard to quarantine someone who isn't sick.
Right. So
you don't have a fever.
You might not have any symptoms.
You might not have any symptoms or minimal.
But you're carrying the virus.
You're still spreading the virus.
Okay.
So that's what the big worry is in terms of its spread. As far as the virus, the severity of it, it does not seem like the 1918 flu.
Right, which was a nightmare.
It was a nightmare, and it killed young, healthy people because they had no immunity to it.
And millions.
In the millions.
Yeah.
But this does not seem to be like that. The people who are dying are, I don't know the percent because you don't know the total number of infected, but it's probably more like influenza in terms of a percent or something, and the death rate is more common in older people and people with underlying cardiopulmonary disease. So it seems to be
people.
It doesn't seem. It seems like obviously this year so far we've had many thousands more deaths from influenza than from this virus.
And we don't talk about that
don't.
much in our country.
Yeah.
I mean, thousands have died already this year, right?
Yeah.
And last year and every year. So that's kind of interesting too.
So I think there's still an unknown, but that's how I see it right now. The one thing I would like to get back to that you had asked me in the questions you sent me was a little bit about the universal health care, the Medicare for all, because right now we're in the middle of an election.
Right.
The number one topic in the country is what's going to happen to health care, and that's partly because it's so broken. And what's broken is not so much the delivery of the health care, but the reimbursement and the costs out of control, the reimbursement, and that's because that I think is a crucial. And I do think that we are likely. I don't know if it's going to be Medicare for all, but it's likely to move towards some kind of universal health care with a single payer system. I think that would be beneficial. And I always think back to...
That's really good to know.
I always think back, I have a good friend who second-generation immigrant from, family from Italy, okay? And their whole family moved to the Detroit area. And half of them settled in Detroit, half of them settled in Windsor, Canada. Those two are sort of like twin cities. They're connected by a bridge. They're not too much different. And so the
Canadian healthcare system versus ours.
So his father died, and they had a huge reunion with all sides of both families, and they gathered together and they spent a day, several months after his death, and had sort of a family celebration of this. And he came back from this meeting and he said, what's really odd is that all of the patients from Windsor loved their health insurance, loved their health care. All of the patients from Detroit hated their health care. But the biggest fear of the people from Detroit is that they're going to end up like Canada, which is sort of like
So they're not listening to their relatives.
No, they are not listening to their relatives. And again, it's not simple. There's not a simple way to get there. It's incredibly complex. But right now the problems are lack of insurance, unfair insurance, underinsurance. There's things like deductible, and then co-pay, and then co-insurance, and maximum out-of-pocket costs. So for many people
people will glaze over.
Right, but many people end up with anyone who gets really sick who is going to go bankrupt from their health care, despite the fact that they have insurance, because to not go bankrupt with a serious illness or procedure, you have to be able to pay $8,000 out of pocket, which people who are paying 26% of their income for their insurance anytime, and then lose their job for a period of time. It's just no way out of that. So that is going to become, and again, it's. Hate to bring it up with 8 minutes left, but this is something that's incredibly important right now. I believe in universal health care, and I believe that it has to be more efficient, and it's got to be structured without some of the bizarre convoluted systems.
We don't want people going
place.
bankrupt because they can't afford
when 2/3 of the bankruptcies in the country are people with health care who have insurance.
Well, maybe I can have you back sometime and we can really dig into this and pull in a couple other economic people who would look at it with us. Well, thank you so much, Scott.
Thank you. Yeah.
It's great
Thank you so much.
It's great to finally.
Yeah.
I've been talking with Scott Davies, who, as we said earlier, was chief of medicine for years and years and years at Hennepin Healthcare. He's now there working with his patients in clinical setting and also doing research. So I hope you enjoyed the interview. I learned a lot. I will see you next week. Until then, have a good week.